Doctors, we are live. You can start the session.
Thank you, sir. Good morning, everyone. I am Dr. Mahesh Shanmugam, convener of the Scientific Committee of the Vitreoretinal Society of India, and thank you for joining us this Sunday morning. Media runs our lives quite a bit, and we are affected by every headline which we see. And this was one of the recent headlines which I came across. That is, 14 million jobs worldwide will vanish in the next 5 years. And this is largely due to AI and its impact on our lives. So the question which popped up in my head will I be one of them? I'm sure many of you are thinking the same thing. And there was another one which said that ChatGPT rated us better than real doctors for empathy and advice. So of course, like I've been in medicine for the last 35, 40 years. So the natural fear is, will I be replaced? On the other hand, there was this disturbing article where the godfather, the so-called godfather of AI, quitting Google, and he warned about the dangers of misinformation. So not everything is hunky-dory, and we have seen science fiction movies about the Frankenstein monster and technology, how it can take over our lives. Will this ruin our lives, run over our lives? And to supplement this, there was another recent headline which said that in a simulation, the AI drone killed the human operator because it was not allowed to proceed with the task given to it. And there was another article, which I don't know if it's really true, that surgical robot killed the man on operating table when doctors were sipping latte. So the doctors are usually at the receiving end even for whatever the robot does. So that's when we thought that, like, let's have a webinar on the future, on how the future is going to change. That is on AI and chatbots, how it's going to affect our future. And to take this through this interesting journey, I have a wonderful faculty from all across the world. And the faculty, in order of their appearance, Mr. Anand Sivaraman, who is the Chief Executive Officer of Remedio. He has been working with the AI and incorporating them in his cameras for quite some time now. And Dr. Kim Ramasamy, my close friend and the director of Arvind's Telemedicine Network and IT Services, and he's also the Chief Medical Officer of Arvind Eye Hospital, Madurai, and Vice President of the VRSI. He has been very, very supportive of this particular endeavor, and he has brought in faculty from Google to join us. Dr. Dhananjay Shukla, he's here to join us. He's a consultant with the Retina Vitreous Service at the Ratan Jyoti Netralaya, Gwalior, Madhya Pradesh. And Dhananjay can see through things and can tell things the way they are, and without mincing words. So that's his strength, and I look forward to hearing his views. And my young associate, who was my fellow and now a very close associate of mine, to whom I go to whenever I want things done, Divyansh Mishra. So he has done all the legwork as far as this webinar is concerned. Thanks to you, Divyansh. Mr. Mohit Jain, he is the principal researcher in Technology and Empowerment Group at the Microsoft Research India, and his special interest is in developing low-cost imaging with smartphones. And Dr. Arthur Brandt, he is one of those unique people where he has done software, then he has gone to do medicine, and now he is on his way to becoming an ophthalmologist. So I look forward to listening to him because he has seen both sides of the coin, and he worked in Google earlier. Rajiv, a very close friend of mine once again. He is a senior vitreoretinal consultant at Shankar Netralaya. He's a professor, researcher, scientist, and he and Kim have worked with Google extensively in creating AI as far as diabetic retinopathy is concerned. I look forward to listening to him as well. Rupesh, he joins us from Singapore, and he has been extremely supportive for this webinar. He has brought in 2 more of his younger colleagues. And Rupesh is a senior consultant ophthalmologist, clinician scientist, and deputy head of research at National Healthcare Group Eye Institute at Tan Tock Seng Hospital, Singapore. He has been dabbling in computers and AI for quite some time, and he has created softwares to map out uveitis and trauma. I look forward to all the views from Rupesh as well. Aniruddha will be joining us later. He's an associate staff physician in the Eye Institute at Cleveland Clinic, Abu Dhabi. All these are young Turks who are going to shape the way we are going to practice ophthalmology in the future. And so is Dr. Ritesh Narula. He's a consultant ophthalmologist with vitreoretinal diseases, LVPEI at Hyderabad. And the youngest of the lot is William. Dr. William, he's a research fellow, Department of Bioinformatics at LKC School of Medicine in Singapore. And Dr. Lara, who works in AI Digital Innovation Lab in Singapore Eye Research Center. So the whole program is formatted like a debate. So one person speaks for, the other person speaks against. And usually the doctors are speaking against to see how it's going to impact our lives. And the last part of the session is going to be very interesting. We're going to present some 5 cases to experienced ophthalmologists and the young ophthalmologists, and also to ChatGPT as well as Bard or the AI, and to see which of them score and how we are going to benefit from these chatbots as well as AI, as well as where we have to be careful as well. So let's get started and have some fun. And we'll start off with the lecture by Dr. Anand Sivaraman. Stan, can you please share your slide?
Sure. Thank you so much, Dr. Mahesh, Dr. Divyansh, and all other organizers for sharing my screen. Is the screen visible?
Yeah, now it's visible.
Perfect. So thank you once again. Conflict of interest disclosure. I am a shareholder in Remedial, an organization that's focused on AI-enabled portable and multimodal ophthalmic medical devices. Quick introduction to the field of AI. It's about the development of models and algorithms that are able to perform tasks that normally require human intelligence, but it gets there over time. For example, in this very simple example, we talk about images of cars that are actually shown together with what we call the ground truth, which is to say that it is a car and a different type of car, and then asking the question, is the model able to interpret whether a new image is that of a car or not? Now that's a layman's way of looking at it. A little more jocular way of looking at it, which many in the community do talk to us about, is how do you keep adding data to a cauldron? How do you stir the pot in the cauldron and make sure that you keep stirring till you get the right answer? That's another way of looking at it as well. Important for us to distinguish between a lot of what I'm going to be talking about, which is going to be more on the use of machine learning in solving problems on either detection, classification, etc. And that's going to be a little different from what you would be hearing a little later on the use of NLP-based algorithms, which has got a lot of attention with ChatGPT 3 and 4 that are now available for everyone to use. Now, what's very important to understand is the development cycle of an AI product starts not necessarily from just the data collection and curation, but even early in terms of how do you frame the problem. And once you frame the problem, you collect the data, make sure that you train it, you have an internal validation on the basis of the training, and then you integrate it within a device and do multiple clinical trials, especially prospective clinical trials and multi-ethnic clinical trials before you finally deploy the model. And once the model is deployed, you need to keep monitoring the model in order to make sure that the performance is as per what clinically approved regulatory pathways have allowed us to be able to deploy them for. Now, what's very important is there are lots of challenges as we go from the first to the last step. In fact, the very first step is about ensuring that the quality of data is extremely good. And oftentimes you are faced with very differing ground truth. Not every ophthalmologist may agree on what the ground truth associated with an image or data is. And this is therefore something that has to be looked at very closely when you develop these AI algorithms, especially because it's almost like garbage in, garbage out. Unless and otherwise the quality of data is good, what you're going to be able to really get outside later on when you actually start doing prospective clinical trials is not going to necessarily make a lot of sense. Now, at Remedial, we embrace ethical AI development frameworks, and this is something that I may not be able to get into a lot of detail in, but as an industry, there is a lot that is now being defined in what's called foundational considerations for AI development or ethical AI development. Now, if one were to look at the various FDA-approved software as a medical device or hardware devices with an integrated SMD, it's very clear that most of those that are getting approvals are imaging modalities, and therefore ophthalmic sciences therefore has an advantage because it lends itself to AI models because there's a lot which is based on imaging. For example, AI in eye care research in literature, for example, has a lot of AI development that's happening on the anterior segment for problem statements as diverse as figuring out whether a person has cataract or not using slit images, fundus images, grading of cataract as per lobes, to looking at angle closure glaucoma, to the posterior segment where you're looking at detection of chronic eye diseases, as well as progression of chronic eye diseases, both in support as well as autonomous systems. Now, I want to spend a couple of minutes on this slide because the key research question in a way defines how the model is going to be developed and how the model is going to get used. There are various models that can be developed using MLDL, some of which are based on pure classification. For example, if you want to ask a question in ROP, is there plus disease or not? That's a classic classification problem. There is the segmentation problem where you are looking to quantify imaging biomarkers, or you're looking at detection where you're looking at certain specific features, for example, DR lesions. Or you also have now very interesting transfer learning concepts, some of the work that is being done in glaucoma globally, where you're starting to look at multiple types of data, different types of imaging data sets, all the way from looking at OCTs to fundus to perimetry, where you're starting to look at the area of transfer learning. And a lot of very interesting work is starting to come out in this area of research as well. Now, I want to transition quickly to making the case for AI in India for ophthalmic screening. Instead of getting into the specifics of each of these numbers, I wanted all our attention to come to the small gray box where we see that the demand for annualized screening is as much as 400 million in India. And if this has to be executed through ophthalmologists alone, that's going to be each ophthalmologist seeing 100 patients a day, which is just not going to be feasible from a practical perspective. And that's the reason why we feel very strongly that there's need for an affordable, sensitive, convenient, that is close to patient, and clinically validated screening models outside the clinic in which AI forms an important part. Now, the reason why we feel we need to move to a future where today 70% of an ophthalmologist's time today is being spent on finding who has a problem. Whereas we feel that given the paucity of resources and the number of specialists that we have, 90% of an ophthalmologist's time is really got to be spent on treatment and care. From a patient perspective, and we've seen this in clinical trials that we have done in and deployments that we have done in public health centers in India, where patients, more than 99% don't know that they have a chronic eye disease or condition, and therefore they are at risk for vision impairment and blindness. There is therefore a need for close to patient deployment models for identification and screening. Lastly, we've seen this as part of unpublished data as well as published literature, where we've seen that the use of AI for triaging in a way prevents loss of screen patients to follow-ups, where you oftentimes may miss them for a follow-up or a referral pathway. So one of the things that in India we are very focused on is not only using AI and devices from a screening perspective outside the clinic, but also try to create these care gap closures where you're able to link sites of screening to sites of treatment, that is primarily ophthalmology centers. I want to transition to one example of a referable diabetic retinopathy algorithm that we developed, which runs on the device, our fundus on phone device, without needing any internet. So it works on the edge on the Core ML platform of Apple's iPhone. And we've done multiple clinical validations, prospectively, both multi-ethnic and multi-site. And this is now a CE-marked SAMD as an autonomous device, as a class 2 device. And we are working very closely with the government of Kerala to be able to bring this to scale there. Initially, through a teleophthalmology-led model led by Dr. Shobha Prasad, we were able to essentially place devices, the fundus on phone devices, in the public health centers. And what was very interesting is the fact that through the connected care model, where the referrals were actually sent to either the Regional Institute of Ophthalmology or district hospitals, we would start having cases where at an epidemiological level at a PHC, we are able to see those cases where the incidence of DR is higher than national average, or the incidence of STDR is very high. Now, this is one of the reasons why we believe very strongly that there is a need for close to patient screening. Now, these are some additional AI models that we are currently developing, various stages of development. Glaucoma is something that we are actually coming close to deployment as well. Rather than getting into the specifics of the sensitivity, specificity, and other performance, which is the clinical research outcomes, I wanted to transition very quickly to certain problems that we need to actually look at. Framing the problem, in my opinion, is more important than the solution itself. We ask ourselves the question, what is the public health problem we are trying to solve through screening? For example, in case of glaucoma, it is not a trivial problem to answer, especially when staging of disease is not consistent across ophthalmologists themselves. We then ask the question, what is the ROI from a public health perspective for the government? Is the cost to benefit analysis indicating potential for impact at scale? As a company, we need to ask the question, what is the business model to ensure sustainable impact? And what are the touch points where the screening is relevant? All of which are very deep questions that we need to get into And that was one of the reasons we actually had a clinician within Remedial leading the technology team, which then helps us answer these questions a lot easier than if we have a technologist doing this. The role of AI in our vision is that of being able to simplify healthcare access. The first 8 years was about putting out smart connected devices through teleophthalmology-led screening. We then focused on humanizing ophthalmic intelligence, which is to ask the question, how do we build AI models that is able to essentially screen in non-specialist contexts, especially where we may not have a doctor available for grading. We are now asking to start the narrative where if a patient needs to take care of their eyes, it's important for us to heighten the narrative to starting to give them ways by which they ask themselves what their eye health index is. And this is an AI-supported teleophthalmology-led wellness and referral model that we are getting into, where we are starting to look at the EHI or the eye health index of an individual. We are also starting to look at AI being able to solve questions such as how do you build low-cost systems? For example, we are looking at eliminating a blue laser, taking a noisier green laser, but then use AI during development to be able to remove either speckle noise or in case of, let's say, the SLO noises that are usually associated with low-cost lasers that are usually used in development of affordable devices. We are also moving to starting to look at the eye as the organ that you would integrate to look at cardiovascular risk. These are the next generation research problems that we're starting to look at. Finally, I want to end before the next talk, which is I don't see AI really replacing the doctor, but it will result in standardization and extension of clinical diagnosis outside the clinic. But at the same time, we need to be very careful that we don't have a data and insight overload. That tomorrow, me wearing a Fitbit, I come to an ophthalmologist and start asking the question, in addition to looking at my retina or looking at my eye, can he or she also talk to us about what the insights my Fitbit may be giving me? And therefore, it's important for all of us as an ecosystem to start looking at this data and insight overload. That should not happen because we don't want to overburden the system as well. Finally, I want to end with this, which is I think AI can have a huge potential to impact the health of millions if we are disciplined, have the scientific rigor, the ethics, and respect for safety and regulations, and keeping the patient at the center as an important stakeholder. I want to thank everyone in the ecosystem because it takes an ecosystem to impact everyone that has worked with us in clinically validating our algorithms and bringing it for commercial deployment, including partners where we have opened out our systems to allow other AI companies to also deploy their algorithms on our systems as well. Thank you so much once again, Dr. Mahesh, Dr. Divyansh, and everyone else on the organizing committee.
Thank you, Mr. Anand, for bringing it very balanced view. And he did leave us with reassurance that we are not going to lose our jobs. Let's listen from Dr. Kim. Dr. Kim is going to ask us, like, take it next to the next level. Will we lose the battle to AI? Dr. Kim, please.
Thank you, Dr. Mahesh. Can I share my slides?
Yes.
Not able to bring up my slides here.
You just minimize the screen, the Zoom screen. Now it's come, yes.
Yes. Can you see my slides now?
Yes, we can see. Yes.
Well, thank you, Dr. Mahesh and Dr. Divyansh. The topic you have asked me to speak on is, will we lose the battle to AI? Now, that's a very, very broad question, almost like a vast ocean that goes beyond our current comprehension. Really a big question. I'm not sure if I have an answer to this question. I can only speculate based on my interaction with the AI and assess whether we are indeed losing or winning, or perhaps reshaping the nature of this battle. Also want to show that I don't have any financial disclaimers, but I wanted to just acknowledge all the help from my AI assistant for its valuable help, and also to ChatGPT for putting together this talk. Sun Tzu, the ancient Chinese military strategist, once said, if you know the enemy and know yourself, you need not fear the result of $100 battles or 100 battles or whatever. A profound question. In this context, for our discussion, if we treat AI as our enemy, an unknown, potentially challenging force in our profession, then it is important that we understand who this enemy is. I think that Mr. Anand did a wonderful job of talking what AI is. If I talk about the details of AI, I think it will be unnecessary. It's just to say that, how machine intelligence can work almost like human. It is really scarily similar to how the human intelligence happens. They even talk about machine consciousness, where machines will have their own consciousness. But I'm sure this is purely hypothetical at this point of time and just for science fiction only. All of us are aware of the multiple industrial revolution that have been happening in the different stages in the past. And today we are in the fourth industrial revolution with the AI. When steam engines came into the mainstream use, we started missing the horsepower. Then when electricity came into the mainstream use, the concern on losing manual jobs became a big thing. Today, everybody realizes that AI is the new electricity. And electricity has become the mainstay. Without electricity, I don't think there's any life in today's world. After understanding who the enemy is, it is really important, as Sun Tzu advised, that we should know about ourselves. We need to know who we are. As physicians, we must reflect on our own identity and understand what is making us apart. How do we define ourselves as physicians? What is it that truly distinguishes us? I wanted to understand our role better, so I used the Hippocratic Oath, our sacred promise that defines us as physicians. I'm not sure how many of us as doctors have really looked at this Hippocratic Oath. By knowing ourselves in the light of this oath, I thought we might gain new insights into this so-called battle with the AI. In exploring this Hippocratic Oath, I was looking specifically at areas where AI can significantly contribute. And I asked these questions to AI, specifically to ChatGPT, and wanted to know what they felt. The oath calls us to gladly share such knowledge as is mine with those who ought to follow, meaning to enabling the dissemination of medical knowledge. Also, it emphasizes the obligation to apply for the benefit of the sick all measures that are required as in evidence-based decision-making, diagnosis, and treatment. And also, it has a paramount concern on respecting patient privacy. Also, the oath recognizes that prevention is preferable to cure. And these are certain factors where AI plays a significant role, often exceeding the human capabilities. I just wanted to show where AI is doing a wonderful job as far as this is concerned. So if you look at this, how AI-powered knowledge assimilation, dissemination happens, it shows that in this study here, it is very clear how AI capabilities is far superior to humans in crunching data. Imagine for the same number of articles to be reviewed, the humans took about almost more than 1,000 hours, while AI could do it in 25 minutes, which the human brain can match at no point. Also in patient diagnosis and treatment, Anand showed wonderful examples. At Aravind Hospital, we've been exploring the use of AI in care pathways from early 2010. And we've been using this AI in the real-time screening of diabetic retinopathy. As you can see, we have screened more than 230,000 patients since its deployment in 2019. This was possible only due to AI. We could have done 1/100th of this in the earlier. We were doing this DR screening the last 2 decades, but never were able to reach this number. This is to show how AI has transformed DR screening, and it's very important today in the light of, I'm sure many of you have read the recent Lancet article, which shows not 77 million diabetics, but 101 million diabetic people in India. So it really makes it all the more important tool in today's scenario. A recently published article by the Google team based on their experience from real-time deployment of DR screening using their AI tool called ARDA, which we use, breaks the myth about AI and clearly showed that AI by itself cannot be an effective tool, and it shows that it needs multiple human components are required to make it effective and usable. I will not go into the details in the interest of time. I just wanted to mention about this blog that came in. Another area where AI plays a very important role is the clinical decision support system. A tool like Care Studio can give you a specific data that you need without you scanning through the multiple pages of the electronic medical records that you may have. It brings in the relevant data when you're looking at a particular date or a particular disease component or a particular episode. It brings all the relevant data in one place for you to review and make decisions. And this is a wonderful tool, I feel, especially when you have chronic patients like diabetic retinopathy patients or glaucoma patients, understanding their past history. Disease prevention, another important role we need to play. Here, AI can play a much better role, and it shows a lot of promising results in the recent publications. Prevention is better than cure. And to support this, we may have predictive tools using AI. Imagine the potential if we could predict the chances of developing diabetic retinopathy over the next 2 to 3 years for a diabetic person who does not have any diabetic retinopathy at this point by just looking at the fundus photos. It looks like this is a possibility, and we are working on this deep learning model for novel systemic biomarkers and photographs. There's a paper we have written in the Lancet Digital Health this year, and which was a retrospective study, and we are trying to bring in more information into this. It has been seen that healthcare has the highest cost due to data breach among any industry. And today, AI is the most important tool that is helping to prevent this breach. Even Epic and Microsoft have joined hands to use AI for a safer electronic medical record. While AI offers these wonderful capabilities, it also has its own inherent limitations. Again, this is not me, but what ChatGPT said when I looked for it. As a physician, we embody the art of medicine and recognize the warmth, empathy, and compassion, which has great significance in patient care. They form the core of our profession. The oath reminds us the humility to acknowledge our limitations, to say, I know not, and seek the expertise of our colleagues when needed. AI, on the other hand, lacks the ability to experience uncertainty or demonstrate humility in the face of complex medical situations. As a physicians, we see beyond the physical ailment of a patient, which AI cannot, and recognize that the illness have far-reaching effects not only on the patient, but on the family too. This awareness and the ability to provide support and care is humane, and it cannot be replaced by AI. In comparison, we see that AI and human qualities can indeed be as distinct and as exclusive. While AI has its own strength and capabilities, there are certain aspects of healthcare where human qualities play an essential and irreplaceable role. Now, this is a very interesting research conducted by Hutchinson and Reed. It shows that what constitutes professionalism in medicine from the perspective of patients. Through this, can really appreciate the value of understanding our patients to provide compassionate care, as you can see from the list of items that patients feel what is important. Also, how do you define a good doctor? Look at these examples from different eras. In 1980s or 2010, it's no different. While knowledge and skill remains important, these examples emphasize that the importance of human qualities in healthcare, where human values are valued much more over intelligence and skill. It is also important to acknowledge that in the recent times, we have an inflated sense of confidence and fostered an advance in technology in healthcare. And this has led to a distorted proportion of our capabilities. But this very same technology today is humbling us and prompting a reassessment of our capabilities. Now we understand what patients and as we doctors value the most, as these are precisely qualities that AI cannot replicate. Our true differentiating powers as doctors lies not solely in our intelligence, but in our inherent humanity. Abraham Lincoln says, I destroy my enemies when I make them my friends. This sentiment holds true even for us in the context of AI. Rather than viewing AI as a threat, let us embrace it as an ally. By integrating AI into our practice, we can augment our abilities, improve diagnostics, and enhance our patient outcomes. And lastly, the way I see is human and machine and not as in a battle against each other. I believe the recent advancements in technology in healthcare gives us a good opportunity to deliver a much better care to our patients. And I guess our Dr. V, our founder, had this perception long back when he said intelligence and capability are not enough. There must be a joy of doing something beautiful. And this is not something for AI. Thank you, Dr. Mahesh and Dr. Divyansh, for putting this webinar together, which forced me to read more on this topic. Thank you.
Thank you, Dr. Kim, for a wonderful lecture. While Mr. Anand's lecture was wonderfully technical, you spoke our language. Thank you once again. So I invite Dr. Dhananjay Shukla and Divyansh to take the discussion over the next 10 minutes.
So very nice presentation, Kim sir and Anand sir. One question to Mr. Anand. Right now we are in the era of evidence-based medicine. So can AI give us an evidence-based medicine? So like if you are doing a diabetic retinopathy screening or an ARMD screening, so whether AI would be helping us do that?
I think there are two ways. The answer is yes, but it's also about AI is going to be related to what we always call standard of care. The standard of care is where the evidence first comes in from. And AI is a way by which it learns from that standard of care to be able to then give the same evidence, especially in cases where it either makes it easier for the evidence to be determined. Now, that's where we really see the AI progressing. Let's take, for example, diabetic retinopathy. There could be different research problems that one can look at. If a research problem is one of detecting stage of retinopathy, then it's on the basis of, let's say, ICDR scale, which has come as a result of evolution from ophthalmology and with various grading modalities that have gone into it. Therefore, the clinical evidence will be given in terms of the AI being able to stage disease. If the question is actually a little more prognostic, which is to ask the question, today I have someone with mild NPDR. Can AI tell us, will it progress? Is patient A going to be more susceptible to progress to treatment seeking or treatment requiring or sight threatening, or is patient B? Those are harder questions. Those questions need to be maybe solvable, but today with the body of evidence we have, it's too early to say whether we may be able to. An ophthalmologist with a significant amount of training and learning and experience would be able to do a much better job there than the AI, at least the way we see it today. But it's about being able to ask those more difficult questions over time, but do so with a reasonable amount of humility on how we go about solving that.
So very, very nicely articulated answer from a technical side to give a perspective of both the sides that whether it can cover and not. Very, very true. So Dhananjay sir, do you have any questions?
Yeah, actually, first of all, I have a comment to make. Those were beautiful talks, actually. And while Anand talked about, a very important thing, what I learned from the talk is, one thing is the patients do not know they have a disease. That's a very important part. That's why screening comes in. As Arvind has always been doing, as Dr. Kim pointed out about diabetic retinopathy, many of our patients do not know they have diabetes or let alone diabetic retinopathy. And a similar problem is coming now with hypertension also. So one thing is triaging. And as Anand and I read one of your studies in JAMA ophthalmology done in Mumbai. And so this beautifully shows that, so basically, we do not have to fear AI actually, because anyway, medicine is a branch which wants to destroy itself, which wants to eliminate its need. So we are already in a branch which we do not want to continue as physicians, but we want to, maybe improve the human race finally. So we don't fear AI for this reason. And AI can help us mostly, so far as I have read, just refer to us the referable cases. What we did with Dr. I and Kim sir, when we defined the address system, referable diabetic retinopathy, the cases which can the doctor see, as you said, so we don't have to see a lot of junk patients like we do in Arvind Eye Hospital. So they see a lot of simple diabetic with no retinopathy. They're disposed by junior doctors, and only sight-threatening retinopathy comes to us. So that's what I learned from this actually. So beautiful talk. I don't have much questions to add, but I just compliment both the speakers.
Can I ask a question to Dr. Kim on Dr. Shanmugh? Am I okay to ask question?
Please go ahead.
Yeah.
Sir.
Sure.
I'm thinking as the AI is an assisted tool with the doctor, but this friend of ours is also a friend with the patient as well, because previously our assistant used to be our assistant, but now this assistant, in whatever language you can say, will be with the patient also. How it is going to cause a challenge, because this one is shaking hand with you as well as shaking hand with the other person in front. Is it going to be creating a dilemma? What do you think? And as you very rightly said, we have to shake hands with the technology, but on the other hand, the patients are also shaking hand, particularly in our context. Yeah.
Good question, Rupesh. I think the problem is the same as what we have today. It is the same Google that they are bringing in, the Google knowledge that they bring in, and then they ask the same question and they say, Google says this, and this is exactly what they are going to say with the AI also. It's going to be no different. And even at that point of time, you are the authority because you are the person who has the knowledge and understanding what is right, what is wrong. I still feel we'll have an upper edge on it, and it's not the challenge is not going to be any different.
Yeah, because that's what I'm just getting more and more, because Google, if it was vague, this is getting more specific. And if these chatbots, which Rajiv is going to talk about, is going to kind of end towards that, which patients are going to use, we really, let's see. Yeah, that is one question which is really bothering me, which we'll see. Yeah, something.
Narula has something to add.
Yes.
Hi, Dr. Kim. I just want to qualify Dr. Rupesh's question there. This is a concern which I have been also having. Today, we are talking about AI working as a screening tool, helping us to select patients, as Dr. Shukla was talking about. We are going for future into prognostic models. We are going to be talking about that, as Dr. Anand was also, Mr. Anand was saying. And then we are going to give a number to a qualitative entity. The patients are going to come to us with numbers. The AI told me my predictive visual acuity would be 20/30 as per the AI model. So we are giving a value, a number to a entity which otherwise medicine is more of qualitative, certain factors, multiple factors involved. So how are we going to be coming up or dealing with that kind of an entity coming in future? So just to qualify what Dr. Rupesh was putting at.
Ritesh, I think by that time, even we will be armed with that same data or information based on similar calculations or, what they are using AI for. I think we would be equipped with that kind of information when those situations arise. Just as much a patient can bring in that, I'm sure our scientific knowledge by that time would be that much grown that we'll be able to answer that. That's what I feel. I don't know. Others may.
What the problem is, like, we have to deliver that now, Dr. Kim.
Yes, today we are doing the same thing with whatever information that we have. I think that's the same thing is going to happen at that point of time. I'm confident that should not deter us in any way.
No, what I'm saying is, if there's a vitrectomy and DR removal and the AI says you are going to get 20/20 vision and patient doesn't get 20/20 vision. So that's what I'm asking. Yeah, Rajiv, you had something to say?
Yeah, I think we should not be worried about this fact because the questions would be asked by us. It's a clinician driven, usually the research. So I doubt that we'll have an AI algorithm which will just predict the vision alone. There will be many other factors which will come into play. So it's exactly garbage in, garbage out. The data which is being fed in and the questions which will be asked by, it would be driven by clinicians. I think not be worried about that virtual tell that what the aftrectomy. No, I I think it is too far-fetched thinking that this may happen.
Sure. Yeah, Mr. Anand, you want to say something?
Yeah, I was just going to add to what Dr. Rajiraman talked about. There is the AI part of it, which is about, as was pointed out, it's always about tracking a certain standard of care. It is going to be doing as well as what the standard of care ground truth is taught to it. There is, however, the second part, which is the generative component, as what's happening in ChatGPT and others, which is the second part to it. And there, yes, the questions are fairly valid in terms of making sure that none of these questions that then generate answers that the patient then believes is true. Yes, there is a chance and there is a risk that we should be cognizant of, that it does not cause the faith and the intent behind the doctor to be lost. And that is something that we as technologists equally need to keep in mind when NLP-based models are starting to make their way in the patient domain. And that is something that I think is a responsibility that tech developers also have, like us.
Yeah, possibly it will make us all consciously disciplined and more careful about like our everything. The way we talk, the way we do surgery, probably it will improve the overall outcomes for us as well as for our patients. So are there any more discussion points, Dr. Divyansh or Dr. Dhananjay? Are there any questions from the audience?
So there is one question from the chat box. Shall I read out or?
Yeah, please go ahead, please.
So the question is by Dr. Rajesh from Bangalore, suggesting, respected sir, isn't it possible that in due time AI must also learn to be emotional and may respect a human closely? So what would be the comments by Anand sir and Kim sir?
I have no answer for that. The technical person can tell me. Anand?
To be honest, I'm going to be equally point in saying that foundational models like NLP models are in its infancy today. I don't think we understand that area well enough today for us to necessarily say what needs to be done to be able to enable that to happen well. At least I don't understand that to the level of detail that is needed to have a vision behind it. But it is a fair point that I still feel that we should not be looking at it as independent from the human touch of a doctor. As I said, I in fact see that there is going to be a data and insight overload that a patient is going to have, where I will go to an ophthalmologist and ask questions about what the AI has told me about cardiology or about my cardiovascular risk. So those are going to be what we're going to see. And therefore, the empathy part, etc., is going to come back to the doctor. And it's going to be very difficult, at least as I see, until at least a significant amount of time before we see how the foundational models of NLP are going to play a role with respect to emotions.
We have Mr. Mohit.
Yeah.
Okay, we have Mr. Mohit from Microsoft and Dr. Arthur. Any comments on this question, whether AI is going to have more emotions?
Arthur, do you have an answer for this? You're both an engineer and an ophthalmologist.
Yeah, I think it's a very controversial question and a very philosophical question, whether they'll ever truly be sentient or not. I personally feel like the answer is no, and they're just probabilistic models that mimic human behavior that they've been trained on. But there's others that feel differently, and I also think we'll never truly know the answer to that question.
Mr. Mohit, any comments?
Yes. I sort of agree with Arthur on the last part that we will never know, because at the end of the day, right now it is just mimicking basically what it has learned. It does not understand it completely. Like for example, even if you ask it to add two numbers, it may or may not work. And so it is not understanding what actually even a very simple operation like addition means. Okay, it is a language model. So language it understands really well. But anything which departs away from the language, basically any kind of science, whether it is physics or even like very basic math, it tries to think it through. Like there are few ways by which you can ask it to like think step by step. or there is a chain of thinking. So you can do COTS or step-by-step process, and it may do a good job, but it is not it is not good at those things right now. But that said, people have been very actively working on these areas. Like there are models trained now which can do maths really well, or there are models trained which are explicitly focusing on science or the medical aspect of it. So we can a children who is really good in English and Hindi or all languages. Now that child is being trained to be really good at all the other subjects as well. So who knows? In future it may change. But yeah, but knowing the answer whether it is sentient or not is the tricky one. I think being empathetic, I think just because it is language and empathy requires you to put it in certain words, the empathy quotient. So that part it can replicate a human really well. Even now, if you ask it to act like an empathetic doctor, it can ask oh, thank you for answering this, answering, and really sorry to hear that. So all of those empathy words it can use very well. Whether it actually means it, I don't think so either. Anyways, yeah, that's my 2 cents.
Yeah. Thank you, Mr. Mohit. Yeah, yes, Dr. Rupesh, last comment, and then we go to the next session.
Yeah, I was thinking about it, and it can be a very useful tool. As much as we are asking AI to help us, we should also help AI, because we can't be just taking it from the AI. And how we can help AI to develop this is by using it for an education for our medical students and resident and junior doctor. What we can get writing is scripts for patient counseling, complaints, and how do you become more kind of a connected doctor. As Mohit was very rightly saying, the words which it can be used, how do I counsel or pacify a patient who is complaining? How do I kind of use the words and script? And if we can start integrating that in our language, which sometimes can become very monotonous, I think we can become probably the better person as we are. And if we start emulating, means more and more language and more script it can give, and we put it what AI is trying to tell us. The AI, poor guy, cannot tell anything, but we become the voice of the AI there, what words he is trying to say. Then yes, both put together can become a bit more empathetic, bit more patient caring. I don't know whether Anand will agree and Arthur will agree with that approach. I think that's where probably we should be moving forward, both complementing each other, doctors and AI. Yeah.
Thank you, Dr. Rupesh. And we'll go on to that forms actually a nice basis for going on to the chatbots. The next session is on chatbots. So I invite Mr. Mohit to talk to us about looking into the future myths and facts about ChatGPT. Mr. Mohit, please.
Yes, let me just quickly share my screen and we can do that. Okay. Yes, is my screen visible?
Yeah, it's visible. Please go ahead.
Okay. Yes. Yeah. Good morning, everyone, and thank you for the amazing discussion. And thank you for inviting me. It's a pleasure to be here to listen to all of you. And I come from a technical background. I'm a PhD in computer science. So hence my take is very different. And yeah, so with that, but over the past, so let me just quickly give a brief about me. Like I am Mohit. I'm a researcher at Microsoft Research Lab in India, which is based out of Bangalore. And my main work focuses on low-cost diagnostics. Basically, I develop cheap, easy to use, portable, smartphone-based medical devices. I will talk about one of such work very quickly before moving into the more exciting thing and basically the flavor of the season, ChatGPT. Okay, so so the aim of my work is to democratize healthcare, and my vision is to develop low-cost smartphone-based diagnostic solutions with AI assistant embedded in them. To enable community health workers, teachers, primary clinicians, and even Swiggy or Zomato delivery personnel to perform preliminary screening of certain diseases with minimal amount of training. Okay. With that vision in mind, over the past 4 years, we have been working towards developing a variety of diagnostics tools, from keratoconus diagnosis to blood pressure estimation, all using smartphones. These works have been done in close collaboration with hospitals and NGOs. And let me quickly dive into the keratoconus diagnosis system here. So here is the video will run while I'll talk about it. The Smart Casey, which is the name of the project, is a smartphone-based corneal topographer, and which is used for diagnosing keratoconus. This work was done in close collaboration with doctors from the Sankara Eye Hospital. And the Smart KC system has 3 key parts. So the first part you're looking here is the 3D printed Placido disc, which can be very easily assembled. And it is very cheap. It is only like around $30 and weighs around 150 grams. And this is how the Placido looks from inside. Okay. Now moving on to the second part of it, while we were deploying it, we found there was some issues around alignment. So we added some real-time on-device image processing so that it can help even a novice person to collect data really well. So you can see that whenever it aligns, basically the Placido's principal axis and cornea's reference axis are well aligned, it automatically clicks an image. Okay. And finally, to generate the corneal heat map, it goes through again an AI-driven image processing pipeline to get the axial and the tangential heat maps. Okay, here is a quick snapshot of the result. As you can see, the heat maps generated from the medical grade topographer, which is on the left-hand side, and the Smart KC device, which is on the right-hand side, look fairly similar. And when we actually asked the doctors to rate them based on the keratoconus, whether it is keratoconus or not, we found high sensitivity and specificity of above 92%. Okay. So yeah, so similarly, we have done some work in retinoscopy and right now exploring dry eye and a few other things. Okay, so feel free to reach out to me if you have any questions around these, and we have multiple research papers in each of them. Okay, now moving on to ChatGPT. Okay, so first of all, just for fun, I asked, because the topic was around the myths, facts, and the future of ChatGPT. I asked it to write a poem that what it feels, whether it is sentient and whether it can actually introspect and say what are these things. Okay, so it came up with this 5-stanza poem, and I found like few things to be very interesting, and I thought these are actually true. Okay, so it starts with that, like, some of the myths about ChatGPT are that it knows everything. There is a myth that it can replace doctors and nurses in caring, that it has emotions and intentions of its own, that it can always understand what is shown. Okay, but there are some facts as well, that it is very limited, that it needs human feedback and guidance to be corrected. It's only a tool to augment and assist, and it relies on context and prompt to exist. Okay, very well said, and I'll go in some detail about it later as well. Looking into the future, it says that like it can be an excellent tool to help healthcare professionals and patients alike with better communication, education, and insight. However, the key point is that the ChatGPT will always need human oversight. Okay, so I completely agree with this part. Okay, and not only that, I think like ChatGPT, the 2 key areas where even Bill Gates and many others have said, even Sam Altman has said, where it will have a major impact is global health and education. And the main reason is that like these are the areas where AI can help reduce inequity if it is properly targeted, and there should be the key focus. Okay, and also, sorry, the reason was that like there is not enough workers to meet these needs in health and education. So moving on to the what it can and can't do. Okay. So I try to come up with a list here based on my understanding of the current ChatGPT, and I can see that some of these things it can do really well right now. Some of these things it can't do. Many of these things may change over the next maybe 6 months or even a year timeline. But let's see. Okay. So right now, the ChatGPT can answer questions about common medical conditions, symptoms, treatments, medications, and offer lifestyle and preventive health tips. Okay, so that it can do well. It can even help understand medical terms and jargon. As someone rightly pointed that for junior doctors or people who have just started studying medicine, it may be a good tool to learn stuff. And even for experienced doctor, let's say you are in an ophthalmologist, but you want to read a paper which has cardiology plus ophthalmology in it. So it can also help you to learn something about cardiology. So that kind of thing. And even for patient, it can be a good learning tool. It can also help with to assess your symptoms. So right now people go to Google for everything, that I'm having a headache, what to do. And you get like the first articles like lead to somewhere around cancer. So it can give you like a more responsible answer to it. It can give you like proper triaging and help with your symptom checking. And that is about patient. It can also guide the patient whether you need to seek immediate medical attention or not. Not only that, for doctors, it can help them again with different disciplines. You are of discipline A, you want to learn about discipline B, or if you want to see that like whether the patient has this symptom which is about discipline B, so you can learn about that. Specifically in the case of mental health, it can help with having conversation with the patient, offering some kind of general support and coping strategies. Finally, I think the easier task which it can definitely do and like hit the ball out of the park is that it can help to collect patient data, as in like their medical history, their symptoms, other kind of relevant information. It can handle their insurance related queries, and it can also help in scheduling appointments and do other kind of like more peon related stuff, which can do very well. Okay. Where it can't do, I think it cannot diagnose medical condition at all. Okay. It can provide general information about the symptoms. It is not a substitute for a professional medical evaluation, because I think that also requires you to do a lot of physical examination, also like the facial expression of the body language of the patient, and do a bunch of medical tests and require some clinical judgment. So all of that, it is a big no-no to use ChatGPT for. It is not, it cannot provide personalized medical advice, for example, because you have been seeing a patient for the last 10 years, you know that like what are like how the patient works, what are the do's and don'ts for that particular patient, which again, a ChatGPT kind of system would not be able to do right now. Okay. It cannot offer any kind of emergency assistance, and it lacks any kind of ability to show empathy and natural emotion. I'm adding the word natural emotion because it can mimic an emotion, but it can't show it naturally. Okay. And finally, I think someone else, I think Anand or I think a previous speaker also raised it, that like humans right now, they don't trust these chatbots for their healthcare condition. It will take a long time before they move on like trusting them. Okay. Like humans don't even trust like with AI bot driving their cars, like which is like much easier thing compared to like going into healthcare. Okay. Finally, I think there is again an issue of privacy and security, which is less so in an Indian context, but more so in a European and American context, that like all of these models like store the data and we'll use it for more research and improvement purposes. So, and you don't want to give your health data to a bot. Okay. That said, we have seen some application of healthcare. So this is one of the applications which has been more talked about, and also because Nuance was acquired by Microsoft, so I know some bit more about it. So this is basically the DAX system which Nuance has, where actually there is a clinician and a patient conversation is there, and provides a nice summary or something that can be put up in the EHR record. And you can see that like in this. The clinician might ask the AI bot that like, or the ChatGPT that please summarize this encounter. And we all are aware of the hallucination. It may give a really good summary, but it may hallucinate something. Like for example, in this case, it hallucinated that the BMI of the patient is 14.8, which was not mentioned anywhere in this conversation. So the interesting part is that like it knows that it is hallucinating. It like you can. So this is what like the I don't know like these are called as that emerging properties. People are not able to understand why this happens. So if you ask the same GPT-4 again, that can you check the proposed note, identify any facts in it that don't appear explicitly in the transcript. Okay. And then it says that like, oh, that this patient BMI was not revealed to the doctor or mentioned by the clinician. Okay. So this is, then you can ask it again. Okay. That the patient weight was this, the blood test that this was this. Can you revise the note accordingly? And then it does a good job of doing it. So if you iterate over it with the same GPT, then it can do a better job. Okay, this was one interesting finding I wanted to share. Apart from that, I have been working on a few projects of my own, and again, in collaboration with different facilities. So I'll just quickly go over these projects. Again, if any of you are interested to collaborate on it or want to know more, please reach out to me. Okay, so the first project I'm working on is actually developing a cataract bot. And this is a work which is in collaboration with the Sankrai Hospital. And it is a LLM powered bot to help patients and their caregivers get answers to their pre and post cataract surgery related queries with the doctors in the loop, because I don't trust chatbot to give you correct response. So the way it works is that the patient can ask question in any language and using voice as an input, and the chatbot quickly gives a response. Okay. And then what happens is that the response goes to a doctor as well, asking that like, was the response correct? And the doctor says that yes or no. If the response is incorrect, the doctor specifies the correct answer. And then we update the answer saying that like, oh, this is the answer. This is the final answer, which is the answer combining the chatbot response and the doctor response. And we also update the knowledge base with this, so that the next time when the patient asks this question, it gets the correct response. Okay, we plan to deploy this bot soon, and we are going through the ethics approval process in Sankra. Okay. Apart from that, I think earlier I said that like, yeah, the chatbot can be used to help with the patient intake, because in European context, it's a big problem that like most of the time when the patient is actually interacting with the doctor is just typing some notes because they have to fill up the EHR to get money from the insurance. But so in that case, what we are trying out, this is a work with the University of Toronto. So in a Canadian context, is that before visiting the clinic, the patient fills up, like talks to a chatbot to get all the patient intake related information, like what kind of problem they are visiting for and how long the symptoms have existed, if they have treated it, if they're like the family history and everything else. And then the doctor gets a summary of that to actually optimize their time for having the face-to-face interaction with the patient. Okay. Apart from that, the third use case I'm exploring is actually working with some NGOs in India to help community and childcare. Many times they are not aware of these answers, but there is like this 7-module book, which is almost like a 1,000-page book, which has been made by the government of India, which has the answers to most of these questions. But again, the ASHA workers may not remember these answers. So what we are doing is that the ASHA workers can actually ask these questions, let's say in Hindi, and then we actually use this knowledge base of this 7-module book to get answers to the ASHA workers. Okay, so that's another use case. We're exploring other few use cases as well. So with that, I'll just end my talk. It's a short talk, but I wanted to have some time for discussion and question. Okay, thank you.
And thank you so much, Mr. Mohit, for introducing us many things, including hallucinations about machines. Like I have difficulty dealing with my own hallucination. Now I have to deal with hallucination from machines. So let's go on to the next talk. Before we have the discussion, I invite Dr. Arthur Brandt. As I mentioned, he has a very interesting career path. He's been an engineer, now he's a doctor, and he's on to becoming an ophthalmologist. He's again going to talk about like myths and facts about the chatbots and particularly hallucination. Dr. Arthur, please. You're muted, I think, Dr. Arthur.
Sorry about that.
Yeah.
All right. Thank you so much, everyone, for the opportunity to speak. It's a true honor. My name's Arthur. To get started, I'll zoom back just 12 years ago when I was a freshman at Stanford studying computer science, coming from a small town in Ohio. And I remember there was so much hype about AI at the time. And there was this major leap forward out of Andrew Ng's lab. And this was actually the paper. This was like the biggest news at the time. They were able to accurately label 16% of images in ImageNet, and they performed particularly well at labeling cats. And this was, this monumental breakthrough at the time. Zoom forward just 12 years, and now we have ChatGPT, which is on a completely different planet. I asked ChatGPT to give me a few examples of what it can do, and it's truly remarkable. Customer service, it can write code. It can probably pass most of the software engineering interviews at Google, and maybe it can pretend to be a physician as well. But I think one thing that we need to keep in mind as we're in this honeymoon phase, looking at just how many things that ChatGPT can do well, is that just because it can do so many things very well does not mean that it can do everything very well. There very well may be some limitations, and there's maybe some things that it performs very poorly on. So since this room's full of many physicians, we'll start with a case. We have a 28-year-old male presenting with auditory and visual hallucinations, reporting distorted perceptions of reality and engaging in conversations with imaginary entities. We'll go through a quick differential diagnosis for hallucination. We have schizophrenia, Parkinson's disease, Wernicke encephalopathy, dementia, delirium, Charles-Bonnet syndrome, and substance use. But now we actually need to add one more thing to that differential, which is large language models. This talk actually parlays very nicely from the previous talk, so thank you for those wonderful examples. LLM hallucinations are defined as generated content that is nonsensical or unfaithful to the provided source context. Others have described it as realistic, but not real. And this is important. The novelty of having an AI bot that can semantically write such beautiful language is very enticing, but it leads to a false sense of security in some situations. What's the etiology of hallucinations? There's a couple of things. One is, for some large language models, they're built with too small of a training set, and they don't have examples for some of the questions that people ask them. You can have a very large data set, but it can be biased. And this is one of the, the biggest underappreciated flaws with big data is that just because you have 1 million patients or 10 million patients or 20 million patients, if the quality of the data is low, or if there's some systemic bias with the data, for example, if you're looking at visual acuity and you think you have best corrected visual acuity, but you really have a mixed bag, it can lead to false results. Another issue is that many of these large language models don't update in real time. They're snapshots from previous data sets. So they can be a year out of date, and things can change in a year, especially in medicine. New black box warnings can come out. New drugs that become the new standard of care can come out. And finally, there's always the trade-off with creativity. So what do I mean by this? Well, chatbots shouldn't always output the exact same result. There needs to be some entropy. They're stochastic. And we want them to be creative. In some certain contexts, we want them to come up with new or novel things and not just regurgitate what's already in the literature. And a couple facts about creativity versus hallucination. There's a very interesting paper here that goes into some of the mathematical underpinnings of the large language models. And I think two facts are quite interesting. One is that the rate of hallucination is provably higher with less specific input prompts. And this dives into the whole area of prompt engineering, or how can you, as the user of ChatGPT, ensure that you get the best outputs out of it. The second is that once ChatGPT or other large language models begin to go down a path of hallucinating, the rate of subsequent hallucination actually goes up. So you really got to catch it early once it starts hallucinating within a conversation. Is this a feature or a bug? Well, I think that depends entirely on the context. There's a trade-off to be made. In some sense, you want it to be creative. For example, if you're asking ChatGPT to write you a new poem, you don't want it just to regurgitate what's already out there. However, in medicine, you probably don't want to be too creative. You want to stick strictly with what's within peer-reviewed journals or within textbooks. And it's potentially mutable by context. I think the final conclusion is that hallucinations are not necessarily going to go away. They're probably inherent with the underlying technology of these foundational models. And while we can probably mitigate or reduce the rate of hallucination, we as physicians need to figure out if we're going to use this, or if patients are going to use this, we need to, be the human layer to protect patients from these hallucinations that will probably always be with us. So a couple examples. Example one, the ER physician in the US was curious how good ChatGPT was if he just took his exact HPI from his note and plugged it in. So he went through 40 of his patients, anonymized the records, plugged it into ChatGPT, specifically asking for their top 6 diagnoses on the differential. And it only got the right diagnosis 50% of the time when asking for the top 6. Notably, it missed an ectopic pregnancy, which is a fatal condition if untreated. However, it did get an orbital wall fracture, so maybe there's some hope within ophthalmology. Why did it miss these? Is there a true art to the medicine and perhaps the clinical cases that present to us in the real world are nuanced and require something that's innately human? Maybe alternatively, when ChatGPT was trained, it didn't have a ton of very sloppy notes from Epic where a bunch of abbreviations are used, partial sentences are used, and it's just unstructured relative to the USMLE questions or OCAPS questions that it can perform quite well on. Someone else published this. Unfortunately, the literature is quite sparse because it's still very new, but someone else asked the same question, 36 patients, asked for the differential diagnosis, and it got the right diagnosis 60% of the time. So this is, we think of ChatGPT and this whole new technology as miraculous, but 60% of the time having the correct diagnosis on your differential would get you flunked out of med school. So we need to be cautious. Second example is if we use it to literature reviews in research. So this is one of my professors, Dr. Kwan Nguyen, and I was asking to list some of the landmark studies within diabetic retinopathy, and it notes that he studied the effect of Avastin in a small group of diabetic macular edema patients back in 2006. And it seems quite convincing when you read the statement, except it's categorically false. He looked at an anti-VEGF trap back in 2006 for choroidal neovascularization, and he looked at ranibizumab for diabetic macular edema, but he never looked at Avastin for this. Although if you read it, you'd probably believe it. So what's happening there? Well, it's an algorithm that predicts likelihood of the next word within a sentence. And given how much overlap there is within the anti-VEGF research, we use it for everything. It decided to spit out Avastin instead of one of the other drugs that he used for one of his papers, but it is categorically false. So how do we cure hallucination? We've got a couple drugs on the market already. But for this particular use case, the antipsychotics probably will not work. And instead, we need to make sure that if we're going to use this for medicine, we need to get a very good training data set. We as users of ChatGPT need to get better with our prompt engineering because we can, provably decrease the odds of hallucination with better prompts. And finally, we need to trust but verify. I love the example that Mohit gave before, which is that ChatGPT can catch its own errors. And this opens the question as we continue to validate within the medical context, perhaps layering ChatGPT on top of ChatGPT could actually lead to much better results. You can imagine a world where after it generates your patient note for the first time, you can ask ChatGPT to verify that it's correct. And then you can ask ChatGPT to verify that it's correct again. And perhaps layering and having it triple check itself could lead to better results. We'll see. So do only large language models hallucinate, or does anyone else? Well, for a while during the COVID pandemic, there were many physicians prescribing ivermectin for COVID. And originally there was a paper that maybe suggested that this could be effective, but at some point there were many subsequent studies that suggested that there was no impact. And there is some toxicity to this drug, yet many physicians still kept selling it to patients. So I don't think LLMs are unique in this front. So what's the threshold for safety, knowing that physicians also are imperfect? I think we'll find something similar to autonomous driving, where we slowly roll out the level of autonomy for the large language model. And I think similar to autonomous driving, the bar is actually higher for the machine than it is for the human, and maybe that's for the best. We'll see. At this point, the large language models still withhold medical advice. They deliberately hedge. Anytime you ask it a question, it will say, "I am not a doctor. Maybe you should go to the ER." And they are not going to be major contributors within the major services, but maybe some technology specific LLMs for specific indications within medicine will be able to stop the hedging and give real advice. So in conclusion, LLMs are not perfect. They hallucinate. They will probably always hallucinate, but there may be some ways to minimize that both on our side and on the engineering side. It's not unique. Doctors hallucinate too. And they currently do not provide medical guidance for the major LLMs that we're aware of, but hopefully this can change soon if we can do it safely. I'd like to say thank you. It's a real privilege to speak with everyone today.
Thank you so much, Dr. Arthur. I'm human. I'm allowed to hallucinate. I'm not my computer or AI. That was interesting to know about that. So now that we know the pros and cons, let's get on to the next talk by Dr. Rajiv. He'll tell us how to get smart with chatbots. Dr. Rajiv.
Yes. Are my slides visible, sir?
Yes, it's visible.
So thanks,
There are some
VRSI.
black patches are coming on these slides.
1 minute. I will again reshare it.
Injected by ChatGPT on your slides.
Yeah. 1 minute.
You got all those nowadays, Fly AI and all those things. They are already infringing.
Now is it better, sir?
Now it's better. Yeah, much better. Thank you.
Thank you, Dr. MPS, sir, Divyansh, for giving me this opportunity to talk on chatbots. And difficult topic, and I think my work has been made easy, and I'll be carrying from the last talk, where the last slide was, you should trust but verify. And I'll share some of the experience which we had in verifying ChatGPT for utilizing in diabetic retinopathy. And what I thought that it's important we set our goals correct whenever we are thinking of using chatbot, having specific goals, measurable, achievable, relevant, and time-based goals, and then trying to see how well a chatbot can answer all these things. So I'll be sharing 3 of my studies which we have done using chatbots. And the first one is a thing coming up from the last talk which we heard, that it's pretty good in general medical information. So we wanted to know how reliable chatbot is, or ChatGPT-4 is, in if a patient uses it for knowing about the disease. A person with diabetic macular edema and proliferative retinopathy, if they try using it, putting their questions, we wanted to know how good these answers are. So we had 20 questions. They were all related to definition of disease, symptoms, prevention, treatment, diagnostic method, impact, and even the common questions patient has, that how many more injections I need, what will happen, will I become blind? So about 20 of these questions were prepared. We wanted to know that if we have a standard answer, which we have collected through a proper literature backup through a PubMed search, what is the agreement of the experts regarding that? And also how the experts grade appropriateness and completeness of answer, which is generated by a ChatGPT-4. So we had 3 medical retina specialists, more than 10 years experience. We wanted to have various settings. So there was a physician, ophthalmologist working in a physician setting. We had ophthalmologists working in a tertiary care, and we wanted a perspective from other country too. So we had another doctor from a different country, giving it a global perspective. So this was interesting. So we had all the answers prepared using proper literature search, and we had prepared all the answers for these 20. And here the agreement is about 85%. So even with a good literature support, many of the questions are ambiguous, and the answer, the agreement between the experts is about 85%. Now, we gave all these questions to ChatGPT-4 and got the answers, and we used a Likert scale of 1 to 5. And we asked the 3 experts again to grade them, whether these answers are appropriate or they are not appropriate. And you can see all 20 answers pretty good. So 16, 17, you can see the grade between 1 to 5. The agreement between the experts was about 96.8%, and the average score was about 4.38 out of 5. That seems to be a good grade. Coming to the completeness of the answer, we did the same exercise, and this you can see the grades between the experts. Again, if you look at agreement, though it was a bit less as compared to the appropriateness, the completeness was less, about 87.6%, and the average score again coming 4.38, meaning that probably ChatGPT-4 answers for diabetic retinopathy seems to be appropriate, also seem to be complete. So ChatGPT can be a reliable source for exploring answers related to diabetic retinopathy for our patients. They are appropriate, they are complete, and probably it would be interesting to do. This is a common disease, a very uncommon and more challenging questions where you spend more than 1 hour, 2 hours explaining, like tumors. It would be nice to see how a ChatGPT can answer these questions, whether they are reliable and whether they are appropriate or complete. We also wanted to check whether GPT-4 can be used as a risk factor engine to predict the presence or absence of diabetic retinopathy. This was a work which we did with VIT Chennai. And this concept we have been exploring for last couple of years, that do we really need to pre-screen diabetic retinopathy? So we have about, as Dr. Kim rightly mentioned, about 107 million people with diabetes in India. It's next to impossible having retinal photograph for all of them. So can we think of something which we can do before taking a retinal image, probably a biomarker or a combination of risk factor, and reduce this number from 107 million to some digit less than that, so that retinal image for them can be possible. In this approach, we have been working on the risk factor based diabetic retinopathy prediction models, and we thought that can we give a prompt of risk factors to ChatGPT and see whether it can classify a patient to having risk of diabetic retinopathy, and then compare with the retinal image based on presence or absence of diabetic retinopathy. And then we wanted to have the measures like reliability. So we did this 3 times, the same question, the same data was given thrice to the ChatGPT-4. We wanted to know how reliable are these predictions, whether there was agreement between a ChatGPT-4 and clinical diagnosis, and can we evaluate the agreement between the two. We were also a little bit keen to know that the sample we have used is enough to answer these questions or not. We had about 111 individuals with diabetes. This is the baseline data. And I would explain that it's a little interesting. Initially, we had put only the risk factors, the lab values, and we ran on a pilot 20 patients. The results were not great. In that data set, I also had a central subfield thickness. So we added central subfield thickness to the risk factors and the demographic data, and then tried using did it 3 times, thrice, 3 instances. We wanted to see how ChatGPT gives the diagnosis. So the ChatGPT generated the risk predictions like low risk, low to moderate risk, moderate to high risk, and high risk. And the final response we took was the most repeated response as a final response. And the selection of the final response, we actually divided based on arbitrary about half. Anything less than moderate, we called it as no DR, and more than moderate, we thought it is a DR. We actually did all combinations. This combination worked best. And then this was regarding reliability. So when we did 3 times the ChatGPT results, the result, they were not exactly the same, but it was quite reliable. The interclass correlation coefficient was sufficiently good, suggesting that it has a good reliability and consistency when we use again and again. And that's the agreement between the ChatGPT-4 and clinical diagnosis. So it could predict diabetic retinopathy accurately in 84% cases. However, no DR was less. That means it is, though seems to be a sensitive approach, but the specificity is pretty low. And the agreement also was a fair agreement. The power calculation suggested that this sample size seemed to be enough to answer these questions. So ChatGPT-4 has a potential to be used as a risk factor-based DR detection system. Seems to be a reliable method, and it is sensitive. However, we need to probably look at other risk factors which can improve the specificity too. We thought, can we combine both? And that's a work which is being funded by Department of Biotechnology, a work with Mohan Diabetes Center, NIT Durgapur, and Indian Statistical Institute, Calcutta, where we are trying to use image-based AI and GPT combined for diagnosis and management of diabetic retinopathy. So I think a couple of you who have worked on various data sets are aware about this Messidor data set. It's one of the most frequently used image data set used in AI and developing models for diabetic retinopathy. It has about 1,200 images, and they are all from a non-mydriatic 45-degree field of view. It has got diabetic retinopathy and DME grading. However, this data set, the major problem is the lesions are not annotated. And this study is a part of a larger study where we have 9 graders who are grading more than 5 lakh images in both the centers. And in that, we thought that let's do an annotation of all the Messidor images. So we annotated these Messidor images in terms of all the diabetic retinopathy lesions. And then we thought that now actually the NIT and ISI are developing a deep learning based algorithm to detect these lesions. And we intend to use a ChatGPT to provide the grade and the possible treatment based on the outputs of the DL algorithm and the patient metadata. This is just an example, like the image which I had shown. We just put that this is a right eye, dot and blot hemorrhages, mainly temporal quadrant, has got cotton wool spots in supratemporal quadrant. In the model which we are putting, we are even giving the size, location, all details, but this was just to show how it can work. Hard exudates in the temporal, and they are more than 1,500 microns from the center of fovea. There's presence of NVD, there is no vitrecine, no traction, And this is just a added information. I thought that let's put that patient is not regular on follow-up. And I asked the chat GPT, can you grade the retinopathy and give a possible treatment? So as expected, it clearly said that this is proliferative diabetic retinopathy. And then they said that because there is no vitreous hemorrhage, no traction, treatment can be panretinal photocoagulation. It explained why. It did give an option of intravitreal anti-VEGF, but it said that because the patient this requires a more frequent follow-up, and this patient is not a very ideal patient to give anti-VEGFs in this scenario. So I think this is one of the way probably we will see a combine using deep learning approaches and chat GPT NLP approach to diagnose certain diseases. And lastly, that definitely this is coming a big way. Every day we are seeing new programs, new based on chat GPT, which are coming. And can we use effectively these web pages? How can we integrate it into a web page for a smart search? And this actually yesterday came, there is something called as Chatbot for Science. And this is one of our paper which was published in BMC Ophthalmology, the distribution of macular pigments in MacTel and correlating it with OCT characteristics. And I just thought that let me put a question and see whether from this article, it could give a detail. So I just asked, is there any basis of using lutein and zeaxanthin supplements in MacTel? And it could say that, yes, there are some evidence that it may increase the macular pigment in area where it was present at baseline. However, there are more studies, there are conflicting evidences which are existing. You need larger sample size. So this is one of the way, no need to go through the whole article, just reading the article. If you have some question, you can use, and chat GPT seems to give a good answer to it. And this is my research website, one of my optometrists made, and he integrated actually in the AI model that these are all the papers related to AI, and he has an AI chat bot where you can ask any question related to the papers which are published in this or which have been given in this website. It will give all the possible answers based on that. So coming to the final slide, that what's my perception regarding ChatGPT in ophthalmology, how currently I'm using it. One, I use it as a teacher. Many times when we don't know anything, like I was working on finite element analysis, wanted to know like a high school student, can you explain what exactly it is? It gave a good idea. Many times we have some good ideas. It can help brainstorm these creative ideas. It can generate interesting research questions. And definitely it has a potential of using in a qualitative research, because that's its inbuilt capacity of extracting data from text. And the qualitative study which we did, the first one, actually I asked ChatGPT. Now I have 3 experts, all the answers, how I can, because it is a text data. So it gave the Jaccard coefficient, it gave the methods, how you can do it, though you need to cross-check, but it gave a good insight how to analyze these data. I am using it in scientific writing, definitely helps us create a research paper outline. It helps in writing abstract. Sometimes some passages which are difficult, it helps us to rewrite it. I'm also taking its help in reviewing papers. It also helps definitely some good insights, which sometimes we don't look into. And lastly, we can use it in, it can help or work for us, like drafting email or blogs or social media messages. It definitely gives a more professional look when we use these tools. So to conclude, actually, it came as a post in one of my Facebook thing, that it's, any technology goes through all these, it's a bell-shaped innovation distribution curve. ChatGPT, it seems, is in the early majority. Everybody is trying to use it, and we need to see with time how it develops further. I'd like to thank my research team and my department for all the research work related to ChatGPT, which we have done. Thank you very much.
Thank you so much, Rajiv, for a wonderful presentation. And I think you're one of the people who are using it quite extensively. And probably there's no escaping it. All of us will get to using it some way or other, I guess. So we'll go on to Dr. Rupesh Agarwal, who will talk to us saying if ChatGPT is going to get the better of it.
Okay. Can you see my slides?
Yeah, we can see, but it's not in slideshow mode.
I know I'm putting it. Yeah.
Yeah, sure.
Thank you. Thanks, William, for helping me with the slides, and thanks, Dr. Shanmugam and Dr. Divyansh and everyone for allowing me to speak on VRSI forum. I think this is a topic which I recently started, and after a eventful, very interesting dinner with my friend from Salesforce, we were sitting for dinner, and he said, "Dr. Rupesh, have you heard about ChatGPT?" I said, "What is this new thing?" It was just a couple of months before, and I was not really aware about it. And that night, I came back from dinner at 12 midnight. And after that, that night I could not sleep. I was just checking what all is it. And here we are talking about it. After that dinner. So this has already been spoken. I'm not going to go into the details of it, but some statistics which probably we should be just aware about what's happening. And every day, like COVID pandemic busted, and every day papers were generated on the PubMed. I think, I don't know, William will know probably the latest count of the number of publications on the PubMed, and everywhere in the scientific literature, it's been flooded. I think it's a matter of time when in the next 3 months, you will see every single search engine will show the ChatGPT related papers. So how do we went about checking whether the ChatGPT is there, or do I lose my job? And I was always very confident that as a UVIT specialist, my colleague, my mentor is Professor Kwan from there, Professor Carlos. I thought we always used to think, yes, we are going to be there in the business. We don't know about others. The macular AMD people and the diabetic retinopathy people, but we always thought the uveitis people will little bit stay on. And therefore, what we thought, let's put in the sun classification, which Professor Douglas Jeffs put in 10 years of hard work to get this sun classification for 20 prototypical cases of the different types of sun entities defined there. And then we challenge ChatGPT and some experts to see what are the differential diagnoses this will give against the sun. So this one, this is what we are there. And then we wanted to say on the ChatGPT in this video, what is the most probable diagnosis or the differential diagnosis? And those were based on the criterias which were listed in those 25 papers in AJO for sun classification, the sun 2 classification. And this is what it was coming out based on the most probable diagnosis for this case. And not only this, and then we also ran a webinar in which we wanted to say, as Rajiv has said, the infectious, the image-based and all, where we put in the imaging features, but it was handwritten. Not really, we have shown the image based on the standard diabetic retinopathy classification kind of thing there, because we don't have anything related to the uveitis as yet. Now, coming back to the work which we did on the sun classification, so almost 72% was answered correctly by the ChatGPT, and that's got me a bit scared. Is that, am I going to be one of those the people of that where I'm going to lose the job because ChatGPT is already doing my stuff? And two most probable differential diagnosis where it was able to give quite good. And this is as comparison with 5 years or more experience, they were quite spot on, but we get all the different things. However, having said that, we've spoken about some of the limitations. One of the limitations, as we can say, that we do know that it takes into the consideration the knowledge before September 2021. We just spoke about the hallucinations, which we all know that, and we do know that it can hallucinate quite a lot more than what I and Dr. MPS can hallucinate. It was not created. Basically, it's not meant to be created for medical purposes. Now, I know a lot of people are working on it, including Rajiv, who is working on the diabetic retinopathy. Mohit is working on it, and a lot of people are creating the newer version. And I'm sure the market will be flooded with those medical purpose driven. But the training data has been spoken by, I think, Arthur and a few other people spoken. Where is the data coming from? And I wanted to give one example, an unvalidated website and books to have a look at it. I will change my screen to something very interesting thing. And also we'll talk about the black box issues and the ethical concerns. But I just wanted to show about the accuracy. And I will change my screen to another screen where I wanted to show a couple of things. And this is the ChatGPT. When the ChatGPT came, I said, let me put down who is Rupesh Agrawal. And it says, I don't know about this person, Rupesh Agrawal. And I said, oh, okay, thumbs down for me. So I said, okay, I put in as a thumbs down because it should know who am I? But this is just personal. Now, second thing, which I've worked quite a lot on choroidal vascularity index, I said, okay, let me find out who invented choroidal vascularity index, who was the first person to coin choroidal vascularity index and all those stuff. It was not able to give me the exact information because I was first trying to get the information. But what really bothered me, and that is something which I am really worried about, is the references source which it is speaking from. So I said, okay, I worked on ocular tuberculosis. Let me check with him. What does he say about the ocular tuberculosis? And I said, can you generate the references by Agrawal et al.? So Anirudh is as well there. But let's see, it generated this reference. Fundus autofluorescent tuberculosis serpiginous pruritus. I said, wow, I had a PubMed article which I'm not aware about. This is an article which I'm not even aware about in ocular immunology inflammation. Similarly, I got quite a number of references which came in my name, which are not there. This is Agrawal. Anirudh, you will be happy to see that you've got also some references here. Ocular tuberculosis in non-endemic area, lessons learned in retina in 2018, which I never published. And that got me scary. Is this the information which is coming from there, or this is what we are kind of generating? And this is which is really bothering me, and that is where I wanted to kind of take back to our slides again. And it does probably will have limitation in the terms of accuracy. And again, I wanted to draw the attention of all the audience onto this crowd is that not all published literature are those are peer reviewed, but we have to also take into consideration, and there are quite a number of papers in that, the scientific rigor of it, the methodology of it, the statistical techniques applied are probably not really, really good. If ChatGPT is going to take from those published literature and all, which are already kind of little bit doubtful, then I think I don't know what we are going to get out of it and what use the information which we are going to get. So I think that's something which is really bothering me. Then the last bit is definitely the black box issue, the transparency from where it is coming. Ethical concerns. So I've kind of, William and I, we have just written kind of a perspective and editorial almost on the 7 different aspects of the ethical concerns and many, many different aspects. And not going into the details of it just because of the time constraint. But yes, there are certain things which we have to take into consideration, the biases which is involved, the training which is involved, the patient-doctor relationship, the data protection, multiple factors which will be there. Now, what is the future scope based on it? I think it will probably need to fine-tune and eliminate some of the inaccurate information. How it is going to do it? Probably Mohit and team, Arthur, with his knowledge of ophthalmology and all, at least I'm just focusing on the ophthalmology, will probably be able to see, can it have a real-time internet access without that lag which was showing? And then there are some of these examples there. An NLP-based chatbot, and Mohit, yes, we'll be very interested in talking to you about the UV. That is, we have created some chatbot, but we'll be interested in seeing whether can you help us create something and which can be a little bit helpful for both patients as well as the doctors. So with that, there is a real battle, and let's see whether we can convert this battle into a successful partnership and collaboration, as Dr. Kim mentioned. And I think this is the way to move forward, and where both people work together, both parties work together and use it just like a tool rather than like a complete solution to yourself. Thank you very much for listening. Thank you.
Thank you, Dr. Rupesh, for coming up with the other side and cautioning us as to the limitations. So I request Dr. Aniruddha and Ritesh Narula to take up the discussion.
Thank you, Dr. Mahesh. Excellent talk by Mohit, Dr. Arthur, Dr. Rupesh, Dr. Rajiv. Amazing. Interestingly, we were discussing all the pros, cons, issues, and all together in the same 4 talks there happening. And all our relevant questions have been put forth. So very first, great thank you to putting all those points up front. Next, my 2 big questions which we come to AI and to chatbots typically is the issues with regard references, which Dr. Rupesh also talked about. We still are far away from referencing whatever these chatbots are putting up on the research that is coming up. People do not know the accuracy which is coming forward to it. With ChatGPT-4, these references are going to be coming forward to us. We'll be knowing where this data is coming from, and then we will be able to validate and verify that. So what Dr. Rupesh, you were showing was basically from the older version of ChatGPT. What Dr. Rajiv was showing was from ChatGPT-4, where the references was being shown there on his screen. So that issue will be able to validate and check the information, the source that we are taking for those information. So I think that issue will be targeted about. And second point, which I could sum up with all the four talk, was maybe to reduce hallucinations, we need to have more specific rather than a broad spectrum ChatGPT or ChatGPT-4. The future may be very specific, like an artist-based chatbot versus a science-based chatbot, in one which allow more hallucination or more level of freedom to innovate versus another which is purely more scientific and reference-based kind of a specific chatbots that we may be looking for in future. So a more specific will have lesser hallucination. An artist chatbot will have more scope to innovate, to write a good poem, as Dr. Arthur pointed out. So that's what I could sum up. And no questions, but brilliant talks, all four of you. Had great time listening to all of you. Dr. Anirudh.
I think the talks were really good. I mean, it was fun to listen to so much innovation. But there are questions on the chat that we have which we need to answer. So I'm just going to lead to some of those questions. And while we are discussing those questions, I think it is important for us to understand the level of input that we are putting in. And the level of input that, for example, Dr. Rajiv Raman sir, he put on the chat GPT when he asked a question, he was very specific in asking that there is a patient who has these hemorrhages without traction. And for example, he has this kind of attitude where he's not coming for follow-up. So I think it also depends, the output also depends on what you're putting in. So how confident you are of your own findings. And I think that plays a very important role. So let's go to the first question here. We have from Dr. Jay Sheth, where he's saying he has several questions. So let's ask the first question here. What would be the legal, the copyright or intellectual property issues if you're using ChatGPT for scientific reading? And I think it's a related question, that does the usage of ChatGPT affect its acceptance of the article? So I would like to ask probably any one of you who can answer this, maybe Dr. Rajiv.
Yeah, so now even the publishing houses, they do know that people take help of ChatGPT. I'm on some of these editorial boards, and now they're coming out with the guidelines that you need to disclose that you have used. It's not only ChatGPT-4, but I use more common a Quillbot AI to paraphrase the sentences. So there are pretty good tools which definitely there is no harm. See, it's not like you are writing the whole paper there. It modifies, it makes it better. There are some tasks which we used to really think a lot. That thought process has become less. So like the tool which I use is a Quillbot AI, no commercial interest, but it gives, for each sentence, it gives 5 ways to write it. Now you select best out of it so that it doesn't change the meaning of the thing and it becomes much better text. So for just writing, it is definitely good. It has improved the way. Now you don't get those comments that needs a professional English editor to see through it, even after going through English editing. So I think there is no harm, or it is not ethically wrong if you are using these tools. Yes, if you take somebody's article and just put it, that rephrase it, and take that and print it, it is definitely, it violates all the ethical laws of publishing. But taking use of these tools is not not wrong at all. There are, as far as legality and IP issues, I don't see. And definitely, even though you are using a ChatGPT-4, don't use the referencing tools because it is not meant to give those references correctly. So you can connect the dots. So I had a beautiful paper. It was again a combined study which we did, and it was actually ranking the risk factors of diabetic retinopathy based on some AI tools, which they use it on gaming, the SMART analysis. So I could not give any biological explanation why this ranking and why this association is happening. So I had put in ChatGPT, connect these dots. It gave a very nice biological explanation, though it didn't give any reference. And then I I started digging out the reference and made it as a discussion. So you can still use it. It helps. Sometimes there are certain things we cannot find any, or we cannot think of any way to explain these associations, which you can take help of the thousands of literature which is there.
So yeah, I think the point is it's an open source software as of now. So we don't have legal issues or IP issues at the moment. So we'll just take one last comment. I think I have one comment for Dr. Rupesh, and then we are behind time. So we realized during the study that Dr. Rupesh was talking about that so far we don't have a mechanism by which you can actually upload the entire image, let's say a fundus image or an OCT, directly to the chatbot. And I think that might make a difference in the future, where you don't have to manually put in an input and you just directly upload the image and ask for a response.
Yeah.
So
Yeah.
would anyone like to comment on that?
No, I have a comment. You just introduced in between chatbot and image and the person who's putting Anirudh there, and Anirudh can read images and then you get the information there. I think if you have an expert like Anirudh, then we don't need that thing there. And that was very successful when we saw in our UVIT's ChatGPT webinar on 13th May, and he was giving accurate information too. So if we have information like expert like him, then it's good. But I even don't know, and the people who are asking this, and particularly it comes to the uveitis imaging, are we going to develop the model which is as accurate as going to diabetic retinopathy, where the people have invested quite a lot of resources in developing and reading all those images? I don't know whether the limited number of images in ophthalmology in uveitis with 200, 400, 500 images, 1000 images, whether we'll be leading to those that stage in near future, I don't know. So I think we are way far from some of these things, except maybe some common diseases like AMD and diabetic retinopathy, where we can put in the image based, where it has been validated in glaucoma. So probably 3 things which I can say about, but I don't know about other like inherited retinal disease.
But I think we have to be very careful as physicians, because you mentioned in your talk that the ChatGPT could take up information from any source, any public source, which may not be peer reviewed. And you already have pharmaceutical companies publishing a lot of material on their product. For example, anti-VEGF. We have so many anti-VEGFs now. And you ask the question, I have a patient with resistant macular edema, which drug should I use? And the ChatGPT could come up with a specific answer.
Yeah.
So I think this is something that could be misused by unfortunately the industry or partners. So I think this is something that we have to be very careful about.
Yeah, so I'll just give a very small comment on exactly on the same topic. I'm trying to do some work on the level of evidence. If under the ChatGPT, if we can introduce Oxford level of evidence, level 1, level 2, level 3, I don't know whether Dr. Dhananjay will be able to add to that. And if it can pick up from the literature and get us the level of evidence, that will be again another level which we're talking about the ChatGPT. Then we know that this is something which we can believe coming from level 1 evidence, or just based on expert consensus, which will become level 5. I think that will be something will be interesting. I don't know. Dr. Dhananjay, anything you think about?
Yeah, actually, unfortunately, at this point, I have to agree with Anirudh, because I myself did, I was writing an article on optic maculopathy, and exactly what like he said, it picks up random papers. So as you also said, there is something like the reputation of a journal, the impact factor of a journal, the impact factor of the author. And even if a big author writes in a small journal, we are able to appreciate that, and and we are able to give respect to that article. So all these things are impossible with ChatGPT as of now. So, but a level of evidence
could just be a magazine article. It could be a magazine article. It could be a website. It could be anything.
Dr. Rajiv, to the comment that you had made earlier about using ChatGPT for writing paper or using it to help you write paper, from the other point of view, as a reviewer, if the author has not disclosed his use of ChatGPT to write a paper, are there tools to help us understand whether ChatGPT was used in writing this paper?
To be very true, we are not interested at this stage. Correct. Even if he has used, but now journals are coming up. So now some of the journals like Scientific Report, they have now come out that you need to disclose. But it is voluntary disclosed. So many times people would have used and they will not say also. I don't think there is way to know whether you have used. You cannot.
If you don't disclose, then I mean, this is something we were discussing right before the webinar. Like you will have we had common slide faces in two of our talks. You'll have common wordings or common paragraphs coming up in articles on similar topics or similar field if each of them are using same chat GPT version. So just to keep that in mind.
No, but that anyway would be taken care because they will do a plagiarism check also.
Yeah.
And that those same sentences will not come, though the meaning may remain the same, which many times happens even without the use of chat GPT.
So what can happen is that unintentionally the chat GPT or artificial intelligence could lead us in a specific direction. It could just keep leading us in that particular direction, and we may not think out of the box like humans do. So that's
absolutely correct. So that's what I was telling, that you don't use it to write the whole article. You want some sections, like you are stuck up with something like discussion. As I told, I was stuck up in something. You take help of ChatGPT, but you cannot ask that you write a discussion of that. However, that also can be done in some way. Like I'll give you example. I'm sure many of you know that American Academy abstract, it's a tedious thing writing in so many characters and making
100 words.
100 words takes about 3 hours. This time I had already an abstract which was a larger one, and
Just
in
reduce it.
ChatGPT I didn't even give the specification. I told make it according to American Academy of Ophthalmology free paper, and it made it exactly in that form. So after that you have to still,
too much.
After that you have to correct it. It's not like you have to just take it like that, but it made the work easy. Otherwise, I would have spent about 2 hours. It became easier. So you cannot just take everything from there, but you have to use it as effectively you can use.
Rajiv, you can put there, don't remove the data from the abstract. Then it will keep the data. Otherwise, it removes data.
Listen to that. I hope the residents did not listen to that and they continue.
They are already ahead of us.
On the abstract.
They are already doing it. They are already using it.
I wonder if it can hallucinate a whole paper without any data.
By this time, it could have generated a paper also.
That's going to be a difficult task for any editor for that matter.
Correct.
We can move on, I think.
Yeah, sure. We'll go to the next interesting session. So live kind of a session where we're going to pit the doctors against the ChatGPT. So we have about like 3 to 5 case scenarios. So let's see what each of us come up with. So this session will be moderated by, convened by Dr. Rupesh Agarwal, and Dr. Williams and Dr. Lara will be the chatbot conveners, and the young ophthalmologists who are the young Turks are Aniruddha Agarwal, Divyansh, and Ritesh, and Dr. Dhananjay and Dr. Kim will be the old tycoons. So on each case scenario, they will be giving their diagnosis and what tests to be done, and let's see what the ChatGPT does with the same case scenarios.
Okay, thanks, Dr. Shanmugam, sir. Maybe William, you can share your slides and let's get on with the first case. So we have limited time, but we'll see, maybe we'll cover a couple of cases. So we'll get the seniors team to probably give comment. Who is there? Rajiv, I don't know whether you're in senior is still online. Okay, Dhananjay, you're senior. Okay.
No, Rajiv is senior only. And
No,
so
it was very depressing to see that old thing.
Okay.
First time somebody made me realize that I'm more than 50 now.
Okay, Dr. Dhananjay, this is a clinical case with a little bit of clinical information and an image. You can read about it and then give your interpretation what it is. And we'll keep it very crisp, just some diagnosis and certain key points, and then we'll get ChatGPT to answer for you.
All right.
Yeah.
Got it. Yeah.
Okay, so this is 67-year-old male, complaints of both eye blood vision. Maybe Dr. Mishra, if you want to read, this is your case here.
So the best corrected visual acuity is 660 and 36 in both eyes. He's diabetic and hypertensive. HbA1c is 7%. Anterior segment, posterior PCIOL is there, and intraocular pressure is 10. Can you go to the next slide? Yeah, and this is the case scenario. So, Dr. Dhananjay, what would be your take on this? So what is the diagnosis and what would be the first treatment of choice?
Yeah, the first thing I would say is that the images are inadequate quality, So especially the left eye image. The right eye image could be a severe NPDR or a mixture of diabetic retinopathy along with hypertensive retinopathy. There is definitely a central involving macular edema. The left eye has much more central involving macular edema. So the treatment has to be focused on that. And there is also, I'm seeing a significant element of hypertensive retinopathy because there are a lot of flame hemorrhages, which are there in both the eyes, even though the blood pressure has not been mentioned.
Okay, can we go to the next slide? Okay,
So
more or
this is the
less,
explanation. Yeah, so this is
Go
the
ahead.
explanation for the images. So this is what prompt we have put in for the chat GPT to answer the query. So the fundus both eyes is showing centrally involving diabetic macular edema with moderate to severe NPDR. OCT both eyes shows focal areas of vitreoretinal adhesions with spongiform retinal thickening with large cystoid edema with pocket of neurosensory detachment and multiple intraretinal hyperreflective material, which is probably in hard exudate, left eye more than the right eye. And right eye, the average CMT is 512, and the left eye average CMT is 326 with CME with NST. So
I think it's the
let's
other
see
way
what.
around.
other way around.
Yeah.
Should be other way around.
Yes.
Right.
Yeah, the left eye had the more, yeah. So other way around, yeah. So the left, yeah. So let's see what the chat GPT is supposed to say.
Okay, so William, you can take up this case. You are more senior, right? Here, probably, and then Laura is going into the junior team. Let's see what your says. Okay.
Do you want to see in real time? Because we have already the answers here, but we can do this in real time.
So you can suggest what the chat GPT has suggested, and then you can show that how the real time it would show up as.
Okay, basically we generate a prompt, basic one, asking ChatGPT for what is the most probable diagnosis. When we put this on ChatGPT 4 that we have in here, that is the premium version, he was able to generate a response, and basically he said that the most probable diagnosis for this case is diabetic macular edema with moderate to severe non-proliferative diabetic retinopathy.
No, Laura, would you like to program the ChatGPT command, Laura, with your experience?
So we decided to go for two options, a very naive approach for engineering the prompt. That will be the one that is the most frequent way to do it. That was almost sticking the same case as the one that it was giving to us. And it also managed to have a similar answer. So it didn't make any difference engineering it something, because for what we wanted to do was to have a vision of an ophthalmologist. What would you do with this patient? That was like the initial. And ChatGPT already has this disclosure of OpenAI is not responsible of anything that happens. So it actually consumes a lot of the generated data doing the disclaim information. So we decided to go for a more simple approach, and is the one that if you are working and you don't have much time, you just stick whatever you have on your medical records. And I think it had a good idea of what it was being given, and had a good reaction to it. Like it managed to get a good diagnosis.
Fantastic.
Yeah,
So this case was followed.
Dr.
Dr.
Rupesh.
Yes,
I have an objection with the ChatGPT diagnosis. The first thing is you do not diagnose a great diabetic retinopathy based on a posterior pole image. The second thing is you have to differentiate between the type of hemorrhages, whether dot and blot hemorrhages or flame hemorrhages. And we are not able to see clarity of pictures actually. So especially the left eye pictures, especially the fundus pictures are ungradable. So ChatGPT is focusing only on the macular edema. For example, if the patient has a lot of uncontrolled hypertension, just controlling the hypertension can take care of the macular edema.
Okay, so that one is very important, that as a doctor here, it aged over. So Laura and William, probably the thing is that hypertension is very rightly said, but they never commented anything. The ChatGPT never commented on hypertensive retinopathy or something like that.
Because you didn't give them data.
No, data is there. Hypertension.
Yeah.
No, you did not give them the BP
hemorrhages,
readings.
BP readings are the hemorrhages.
BP reading and the hemorrhages. Okay, interesting. Rajiv?
Yeah, I have only one question. See, which you are putting in ChatGPT, you are already giving him a diagnosis that there is diabetic macular edema, there is moderate and severe NPDR. So what? So it will give. It is just agreeing on whatever you have put there.
No, we are not given diabetic macular. William,
yeah, it is there. It is there. Yeah. Diabetic macular edema and severe the fundus. You are already giving an input in the fundus photo that there is diabetic macular edema and moderate to severe NPDR.
Let's just change it. Let's
Yeah,
just remove it. Let's
Yeah,
remove it.
that
Let's
is
see.
important. Remove that. And
No,
you
let's
can
remove.
actually give the features in the retinal image, exactly like Dhananjay told.
Okay, so let's put in, but it's still picked up.
I removed
now
all
it is
the.
now it
No,
is
no,
the
so it is
thread.
the
It is
chat
the thread.
history.
It is a chat
Yeah.
history it has taken.
Exactly. So you need to start a new conversation and then
Ah,
it
yeah,
won't
yeah,
pick it
yeah.
up.
Okay.
So I
Okay,
think
let's see.
the input has to be very carefully given, because here,
Yes.
You might have to remove destroyed macula image.
Yeah, that's a good point. Yeah.
So let's now engineer a little bit more. Okay. It's good to have just one or two cases rather than let's thinking. Put it. No, William, I will say
Yes,
probably
sir.
OCT also we need to change a little bit of description
Okay.
because OCT is also leading to that. So let's see what all can come. Don't just paste right now. Let's just wait. Okay, bilateral. So Rajiv, what do you want here?
1 minute.
And let's see Dhananjay what he wants.
So in the in the OCT section, you can just write the macular thickness actually, rather than let them interpret they call it edema or not.
Okay, just write macular thickness. That's what patient reads more. Then let's not read qualitative thing. Okay, then what else?
And yeah, so macular thickness gave it the volume, and
BP.
Yeah,
BP?
you should write the exact BP if there is available. For example, you can say it's uncontrolled. Looks like to me.
So you put blood pressure as 180, 110, maybe.
Okay.
Yes, something like that. Yeah, yeah.
Let's.
And I think the fundus picture you can put in words.
Okay, fundus
what I
picture,
had
just put some words.
You can say that, okay, both eye
100
had hemorrhages, microaneurysms, had got hard exudates, which is
No, no,
the
180.
No,
part-
180 by 100.
100.
you
Yeah.
know, in these
mmHg.
cases,
Yeah.
Millimeters of mercury. Yeah, yeah.
Sorry, Anirudh.
in these cases, I feel ChatGPT is, if we can ask ChatGPT to talk to the patient and ask them to come for regular follow-up, that is more helpful than giving us a lab.
So
Okay.
actually, you're right. You are asking ChatGPT for too much actually, because they so far the papers have only found it useful for referable diabetic retinopathy, not for
Yeah.
the management or grading of diabetic retinopathy. Grading is a difficult task. As one of you said, the severity of individual lesions has to be taken into account. For example, a single ARMA of grade 8A, but you can't see a grade 8A ARMA in the picture like this. So that's a limitation,
Yeah.
for grading.
Oh, okay. Divans has
Dhananjay-
written something on that. Can you
Yeah.
copy paste, William, from the chat bot?
Al-
No, he's
also-
written the chat messages.
Okay. Yes.
This is the fundus.
Okay.
Yeah,
Fundus findings.
explanation. Yeah.
Okay.
Retinal
So we
findings.
can
Put
remove-
retinal findings.
Also, more than findings, when we as clinicians are looking at an image, we are working on pattern recognitions.
Yes.
We are trying to give ChatGPT words of that pattern recognition
Yes.
and helping and hoping it to work or into that.
She's
Such a
changing
scen-
now.
Such a scenario, I think it will be more appropriate when an image could be loaded up in ChatGPT and then worked on it.
Yeah,
Mm.
because see, this is NLP based and currently it is not there. That's the reason we are working on both combined approach.
Right.
Using
Yeah.
a image based AI to do that and then feeding the data here.
Absolutely.
But interesting. So I think, as you can see, slight bit of changes, but not really big one. And it was still able to kind of come to command. I think these are enough for ChatGPT to pick up probably.
So I
Okay, but
think it's the same thing that we are doing right now. We are trying to help ChatGPT to come up with a response. So we are at a
Yeah.
stage where we are kind of assisting it, hoping
Yes.
that it comes with the same response,
Yes.
proper response.
But it has already changed the diagnosis to PDR.
Yeah, yes.
So from moderate to PDR, it's a big jump,
Yeah, I
the
think
treatment.
it's like they keep asking me, so I better say something worse.
Yeah.
So to hallucinate more. So that's what was suggested.
It is trying to please us now on the.
What could be
Okay.
the reason why the ChatGPT changed the diagnosis from non-proliferative to proliferative? It is missing
Probably
any keyword
hemorrhages.
here.
You put hemorrhages
Bilateral
in-
multiple hemorrhages actually. So multiple hemorrhages, it presumes they're in all the 4 quadrants. But
Okay.
even then, it should be severe in PDR.
Severe NPDR.
Very
na?
severe, yeah. Very
But
severe.
why it is saying proliferative?
PDR, I don't know what clue we have given to call it PDR.
That's interesting.
Yeah.
Severe form called as PDR.
Maybe some references picked up from someone who has just written some website article on about that. But interesting.
I think you can, I think one thing in the prompt you can do that, you can say that like act as an expert doctor and think step by step. I think these things then help, and provide us provide us a reasoning for why, and
You
after
just
that I
ask,
think
correct.
maybe.
Just ask why it is a PTR.
Okay.
Let's see.
1 second.
Sorry, Dr. Misra is taking a bit of time, but better to have this discussion, right?
Yeah, but it's more interesting to learn what the command should be put in and then how it comes out as a response to it.
Yeah, I think prompt engineering is very tricky, and I think it's also very crucial to get what you're looking for. If you ask it to act like a doctor, give proper citation and or base whatever they are saying based on some medical evidence, and even say that like think step by step, then it actually will probably do a much better job than like directly coming to an answer.
William put why proliferative diabetic retinopathy? Why proliferative diabetic retinopathy?
At least it is accepting its mistake.
It's honest enough to accept.
Honest enough, huh?
Yeah.
It's better than.
So the previous paragraph was a little more like assertive, but right now it has accepted the mistake.
Yeah. We regret the oversight and appreciate our understanding. It has got emotions. It has got emotions, right?
That's great.
That's great. Good. Maybe can we take one more case just to get a little bit idea? If it's okay. I know we are running short of time.
Something different, or do you want
which one?
Case number?
Case number.
It would be nice to see.
No.
There one.
I think we can do one more case.
Yeah, just one more. But which one? Let's see. Yeah. Okay, let's.
One is fine.
Okay, we'll ask young. Who is there? Young guy.
This is the same case, isn't it?
But
I mean, the features are the same.
The features looks to be the same, yeah.
Okay.
You use the other one, either the young patient with that lump choroidal.
And can be a next.
Yeah.
Case 4. Case 4. Go to William. Next case. Not this. Next one. Yeah.
Okay. 22-year-old.
Okay. Who is that? Ritesh?
Yeah.
Okay. Maybe you want to
so
go
this is a 22-year-old female with decreased vision in the right eye. Vision was 660 and 36. Right eye, it's a clear lens, and intraocular pressure is 12 mm of HE. So we can go to the next slide, William. So it is showing that there is circumciliary congestion and some congestion which is more in the fornix. And the fundus photograph is showing peripapillary edema, multiple hemorrhages over the disc, which are flame-shaped, dilated and tortuous vessels, and OCT showing neurosensory detachment with intraretinal fluid and with intraretinal hyperreflective foci, and choroid, which is showing significant thickening and undulations with loss of choroidal architecture. So, Ritesh, Dr. Ritesh, what would you take on this?
In a lumpy kind of an appearance on the choroid, what you can see is undulation in the choroidal layer. Yeah, so ideally in such a scenario, I would first be looking at getting a fluorescein angiography mostly getting done, looking at vitreous cells, AC cells. Would like to rule out an inflammatory pathology happening there. On this just posterior pole photograph, I don't see any other, I mean, other than disc edema, I don't see any other mass lesion or anything. I would definitely like to do a fluorescein angiography and look at the slit lamp for vitreous cells, AC cells.
Is this unilateral? I missed it.
Yeah, it is unilateral.
Yeah.
It is unilateral. And can I take the question?
Yeah.
So,
sure, sir.
I think two missing investigations. One, as you said, fluorescein angiography, but more important, it is ultrasonography actually.
Scan.
So, I would like to have a B scan of this patient's eye, and this look prima facie a case of posterior scleritis.
Okay, so what we should do, William, is let's see whether it is asking ChatGPT for additional investigation as Dr. Dhananjay want, or with this itself, it is able to give you diagnosis. So it is taking into picture is the fundus picture, the clinical, and the OCT, because here it is about the competency of ChatGPT versus a doctor, to whether we are going to save over jobs or not. So that's the idea. Okay, let's see. Okay.
So we want to know first.
Okay, wait.
Which order
this is Shall we go for this first by default?
Okay.
Let's see.
Okay.
Then later on we can engineer to Laura. Then you can start engineering a little bit here.
Very
Ranjay?
nice.
Dr. Ranjay
Yeah,
is
yeah,
taking
yeah.
up VKH.
It's not VKH.
Yeah,
But it could be unilateral VKH, you know.
But it's on the lines of a.
Yes.
It's
on the lines. Yeah.
On the lines.
But again, we asked a diagnosis. We did not ask differential diagnosis. Maybe it could give us a list.
Yeah, and
They said central serous retinopathy and optic neuritis possibilities because of the optic nerve finding that we have.
yes. CSR is a little off the chart because of the congestion, but yes, optic neuritis is also a little far-fetched. But we're going to look at the choroidal. So let's see whether it puts at least posterior scleritis on the cavernous sinus thrombosis. I didn't think of. Yes.
We're still not giving a posterior scleritis yet, right? Okay. What is the take? Wow. Papilledema, CSR, optic neuritis, neuroretinitis.
Yeah, rather than papilledema, should I call it AIU? And if it because it's unilateral actually. So if it was.
So let's go to the command. Was it asked unilateral in the command?
Yes, only right eye they described actually.
So it was not
Only see the
specifically
OD.
mentioned it's unilateral.
You should have said the left eye is normal.
Okay, can we
normal
say
one.
left eye normal? Can we
Yeah.
put?
But you know, one thing that the differential was missed was probably a patient with malignant hypertension.
Again, unilateral, yeah, unilateral. The other eye we saw. No?
Right eye.
So it says lymphoma, it says papilledema.
Say change the diagnosis as unilateral, you put CSR. Wow.
So now it has taken VKH out of the question because.
VKH out of the question as you put it, as soon as we put it as unilateral. Wow. This is completely taken a U-turn. So Anirudh, very rightly, as you said, it depends on
you have
what
a
we
B scan on with and you put in increased nodal thickness, T sign.
put unilateral and put on B scan. Will you like to do additional tests? Can you ask William, instead of this, ask, will you like to do additional tests to confirm or reconfirm?
Yeah.
Which additional test? Put S. If it does not put S, it will only ask you one test only. Yeah, S is important there. Should I order to confirm the diagnosis or the, okay, let's say. Oh, it's still stuck to that CSR only. But did you put, no, okay. I don't see this. It's not still saying B scan, huh?
Because it is now thinking
maybe,
on CSR.
now, one more thing is we did not mention about pain or lack of pain or something like that.
Okay, maybe just.
Or vitreous, did you have any cells or, anterior posterior segment that would change it?
I think this exercise is probably never ending, but I feel that overall, what I take from this case is that when the ChatGPT is assuming it's a bilateral disease, it missed certain important diagnosis, which I would consider. For example, posterior scleritis, or let's say a hypertensive retinopathy, but it gave some unusual diagnosis like neuroretinitis or intraocular lymphoma, which we may not think about. And when you refine your question, and this is what we're doing, it changes goalpost. It kind of changes the diagnosis based on the conversation. So it kind of leads you to a particular diagnosis. This is what I realize, and it keeps falling in the trap. So right now it is trying to justify the answer as CSR as much as possible.
Yeah, just getting there. But I think these are the two wonderful cases. Any final comments, Laura and William, based on your the ChatGPT of other three cases? Can you just summarize two of you, each one, from your learning? And have you prepared a summary table? I think there is a summary table also.
Yes, we had the table. I just would say that Dr. Anirudh told like ChatGPT didn't think in the diagnosis. I think that ChatGPT does not think. It's just association. So that's why when we change one word, he started associating the prompt with a specific entity. So it's kind of tricky because as humans, we try to anthropomorphize the machine, but the machine itself is not able to think. is just associating. So if we put any other word, he will immediately change the association that is doing. So that's why it's important, this kind of prompt engineering when we are using the ChatGPT, even to do a diagnosis or to ask for a specific management. Depending on the specific word that we give to ChatGPT, the answer will change completely.
Great. Laura, your comments on all your these 5-6 cases which you evaluated through ChatGPT.
So almost in the same line that William was telling in the association, and as Dr. Rupesh already mentioned, the prompt engineering needs to be, it's still not very clear for all of us because ChatGPT remains being a black box, and the explainability behind this model is very hard to discover due to the 1,000 trillions of parameters that actually it has right now. So I think it needs to keep on being a tool, and it thinks very similar, although I know it doesn't think, but the process from the input all the way to the output, the steps that it follows is very similar to how we think, the associations that you already mentioned, and the way that it goes through the layers, and it managed to give one answer according to what you put in the prompt. So it's very important for us to be clear, to have a path from the case that you get. I think it's you need to have an idea, and then you guide the machine, and it's just like a standing stick rather than the actual car. You are the car. This is just like a help, like a paddle for making it a little bit better. That's kind of the conclusion we end up getting. Although for the other two cases, that was metastasis and the posterior scleritis, it's still not clear why it didn't even came up with the idea. I might think the metastasis didn't have any previous mention of cancer, so it will be very hard, as somebody mentioned already in the webinar, that it doesn't come up from nowhere. It needs to have some background. So it's very hard to be creative. So if it's not in the prompt, it's very hard for it to even think about it.
Perfect. Thank you, Laura. And I think there's something like, so I think more work need to be done if you have to design chatbot specific to topics. And I think congratulations to Dr. MPS sir and team for designing that chatbot for cataract post outcome. And we want to see that being deployed and used, and we'll love to learn from it. And if there are no, so I think Dr. Vivians, maybe you can close with sharing your knowledge about the Google Bart, which you used it for these cases. And with that, probably we can end this particular session of the talk. Yeah.
So thanks. Yeah, a lot of learning points, as we can see. So it's more like how we are leading the whole chatbot or the discussion. And if we give all correct prompts and all correct inputs, then it would lead on to a correct answer. So except as you were discussing the two, so the Google Bard also had similar answers for both, except for the metastasis, where because it was bilateral and those kind of lesions, which are more like a pattern recognition for a eye doctor to see lesions like this and then identify them. But yes, if there is no past history, and once you add the past history or probably a history of PET scan showing positive, then in that cases, then it automatically changes the answer. So depending how we keep on changing the inputs or the queries and the discussion with the chatbots, it keeps changing the output of the answers also. So very important to work on that. So Mahesh, shall we close the session?
Yeah, sure. What was interesting was when we asked for the differential diagnosis, it did give a couple of things which we weren't thinking about. So that was something. So you have to think for yourself, come up with a list, and then maybe it can like add to the knowledge which we want to. That's what I think probably it is. So thank you for the live demonstration, Dr. Rupesh, William, and Laura. It was very, very interesting and partly amusing as well. At the present moment, it's not going to be amusing when the patient comes and somebody had put, I think Alay Bianca had put it in the chat box, like sits in front of you, attend this like chat box, like ChatGPT when you're talking to the patient about the diagnosis. So it's not going to be amusing that type. But then I think like we have lived through many different problems. I'm sure like we're going to live through it. Like probably like Rajiv mentioned, look at, and Dr. Kim mentioned, so look at it as how we can use it to improve our knowledge as well as see if we can stay one step ahead and go take it along the way. I think that's probably where we're going to take it. And it's going to be a bit more difficult when Raju comes up with image recognition and ChatGPT, and then so you don't need the doctor there in between except for doing laser photocoagulation and giving injections, maybe. So anyway, I think, like, yes, it's been a wonderful learning experience all through the wonderful talks as well as the demos, and the young people taking to it very eagerly, as well as the older people like me, of course, like we are taking to it. Of course, like it's always an opportunity to learn from everything and everyone. And it was interesting to see William give it a gender to the ChatGPT. He always said he. I don't know if I don't know if Laura also wants to call it a he or a she. I wouldn't know, but anyway. Thank you all for a wonderful session. Yeah, Divyansh,
Thank you.
go ahead.
We can take a group
Yes.
picture, maybe.
Sure.
A group photo. So that it's a nice combination of technology, the wisdom, the knowledge, the experience, and the exuberance of the youth. Probably this is the right forum. Yeah.
Dr. Arthur, can you switch on your video?
If I know it's
Yeah,
midnight.
thank you.
Okay, someone can take me. Yeah. I'll take
Smile.
smile. Thank you. We'll share it.
Thank you so much.
Thank you.
So thank you all. Thank you, tech team, Manjula and Sai. Thank you, VRSI. Thank you, Mahesh sir, for giving us the opportunity. And thank you all the presenters and the participants, Mr. Anand sir, Dr. Kim, Dr. Dhananjay, Mr. Mohit, who gave a very good talk, and then Dr. Arthur. And thank you for being awake for midnight. Hopefully it's 12 right now.
More than that, beyond.
Thank you very much. And Dr. Rajiv, Dr. Rupesh, Dr. Anirudh, Dr. Ritesh, and Dr. William and Laura, who very nicely convened the whole ChatGPT as a live session. Thank you very much. Thank you for the inputs. Thank you all, and have a good day.
Thank you, everyone.
Thanks a lot.
Thank you.
Thank you.
Thanks a lot for inviting. Thank you.
Bye.
Bye. Thank you so
Have a
much.
good
Bye.
day. Bye.
Thank you, Sai. Thank you, Manjula.
Thank you, doctor. Shall I end this?
Yeah, please. Sure. Thank you.